repositioning technique, you've got to be worried about real estate. If I lie the patient down and I've got a roller up onto her right side, this is already a problem. So I'm usually going to have the patient go ahead and slide over a little bit more into the middle.
Yeah.
Okay, perfect, yeah. So now if I want to assess, in this case, because I do want to roll her this way so that everyone can see better, I'm going to do a left ear assessment. So I'm going to have her turn her head approximately 30 degrees, again using the reference of the outer ear. I'm going to have her reach up, grab my arm, and I'll usually tell patients kind of like it's a pull-up bar. Because I want to take the stress and the strain off of the cervical spine and onto the abdominals. So we're just going to lie back on the count of 3. Ready? 1, 2, 3. And you can just relax there. And again, the more that you're touching the patient, and here I may ask, how do you feel? Is there any dizziness, any movement? I may take a peek up under the contralateral eye here. And again, this is my assessment. So if she's negative, I'll just sit her up from here. But if I'm going to go ahead and go into the treatment, I'm going to wait for all nystagmus and vertigo to fatigue, wait 1 additional minute beyond that, and now I'm ready to go into my second position here. So I'm just going to have her turn her head, again, so that she's 30 degrees in the other direction. Now, here's the problem with this technique. If she's come in after an MVA or something, and she's bilateral, what have I now done to this ear? So it's problematic. It doesn't isolate the ear. So I wouldn't recommend use it. Again, I'm going to continue to sort of make a case for some of these sideline positions and repositionings. But if you're suspecting bilateral, I wouldn't use this repositioning. But let's say she's unilateral. She may or may not provoke here. It's okay if she doesn't provoke in this position. So now I'm going to prepare the verbiage here. Again, you can tell the patient I like to use my hands as much as I can. We're going to roll Jackie up onto, oh, not yet, not yet. That's actually something that'll happen. So you'll say, I don't want you to move yet, but when I tell you, we're going to roll up onto the right side here.
Okay.
As that happens, I just want you to take your chin and tuck it into sort of your collarbone. Don't move yet.
Okay.
This doesn't need to be rapid, but I do want it to be fluid, so just try not to stop. And then I'm going to kind of adjust where your head is at once we get there, okay? So what is usually a good strategy to use here is lift the knee on this side. Gives you something to grab onto, but also the pillow gives you a nice point of grabbing here. This is usually not as big of an, and once we get into the Gans repositioning too, it's you'll have to sort of strategically calculate what you're going to grab. Because if it's a woman and she's got a dress or something, you obviously can't grab that. Usually men are wearing, some sort of a baggier or looser pant. But we'll talk about sort of ways to get around that and those kind of things also going forward. Okay, so we're going to roll on 3. You ready? We'll go on 1, 2, 3. Again, it's critically important if you're using a narrow plinth to mind this gap. Because in these workshops and in the clinic and things, there's nothing that we want less than for all of a sudden the patient to hit the floor. Now they were unilateral, but now they are bilateral and they're multifactorial. They've got a concussion and all sorts of things. So again, pressing up on the gap here. Again, what we're looking to do is to work the debris around this second bend here. So we want her to be symptomatic here. Let's say she is. Wonderful. I'll tell her it's actually a good thing that we've provoked your symptoms. It's going to pass. We'll wait an additional minute after it passes, and then we're going to do our little, we'll call it a passive or semi-passive head shake. We're just going to lift your head slightly and shake no to the ground. There's always usually someone that's interested, and there's been a lot of research looking at the use of things like a skull vibrator or some of these interesting tactics. Really what the data show is that there's no significant difference when you use these, and also you can detach a retina. So we don't ever recommend using any type of a skull vibrator or any of these kind of things. This passive head shake, what it does is it helps lower our recurrence rates. There can be a little bit of a surface tension to the canal, And just a little passive head shake sort of may help jar free some of the debris that was stuck there. The other thing that's nice is, let's say she didn't provoke here, and I'm wondering, oh, am I going to get a backslide? Have I cleared her? I may have her do that little head shake and sort of reorient where I have the head for more verticality or more laterality or kind of whatever you need here. So I may sort of, rather than sit her up, have a backslide, and then retreat her again, I may just sort of readjust where I've got her head in this position. Does that make sense?
Once the original symptoms pass, or during that time?
Once they've passed. Yeah, I don't want to do any of the movements or anything when she's symptomatic. I want to let everything settle and then sort of adjust what I'm doing. So once everything is passed here, again, waiting an additional minute, I'm going to sit her up. So I'll bring the legs off the table here. Oh, wait, don't move yet. Yeah.
Sorry,
I'm not instructing my patient very adequately.
Yes, sorry.
Okay, Ms. Cuellar, we're just going to sit up here.
Yes.
I'm going to help you. Most of your patients will realistically have the ability to help you here. So if you've done this and you're working with adequate space, your patient will be able to just push on the table and help themselves up. But in the case that that's not possible, or they're biomechanical type issues, we're just going to use the iliac crest as kind of a fulcrum here. So we'll bring the patient's legs off, and I'm just going to help you sit up on 1, 2, 3, and we'll have her keep her head down as she comes up.
You wanted her head where it was on the side,
Yeah.
even if she helped you right
Yep,
now?
exactly.
But you don't want that help.
So
No.
the head is still tucked into her collarbone?
Exactly.
It should stay tucked.
Yep.
Okay.
And the reason for that being is that if you're going to have a backslide and she comes up and she sits up like this, the symptoms are going to be much nastier than if she's got the head tucked here.
Does it have to be to the side she was looking? It can go straight down?
Yep. However you want, that tends to be one that's kind of difficult to instruct on.